Okay, so this month in September, this topic for the September MEC Minute is left ventricular assist devices, or better known as LVADs. Really, the source of the information for the discussion today and for the MEC Minute is this article that was recently published by the American Heart Association regarding cardiopulmonary resuscitation in adults and children who have mechanical circulatory support devices, such as ventricular assist devices and total artificial hearts. With this presentation, as well as the handout, I have included this article, and it's fairly long and it's fairly technical. So what I've gone through is I've highlighted those areas that I think are important to our EMS providers. So if you see something in yellow, I think it's important. If you see something highlighted in red, it's something I think is really important and a key point of the article. If you're a purist and would rather just read the article without the highlights, please let me know, and I'd be glad to send you a copy of the article without any of my highlights added. So as we talk about this, the first thing I want to mention, and just mention once, is a total artificial heart. So what is a total artificial heart? Well, this is a mechanical device that's inserted in the chest. And to insert this device, the surgeons remove the ventricles and then attach the pump to the atria that remain. These are very rare. I'm not aware of any in our community, but you may see one. So what are some of the important considerations for this? Well, it's a mechanical device. You will feel a pulse, but there will be no electrical activity, so an electrocardiogram is not going to help you make any decisions. And the other important part about this device is don't do CPR. It's an electronic or mechanical pump, and compressions will not do anything and have the potential to harm the patient. That's about as much as I'm going to say about these devices, other than if you see one in the community, talk with the patient, talk with the family. Like ventricular assist devices, total artificial heart patients have family members who are very well trained in how to problem solve the device if there's a device failure. So let's move on to ventricular assist devices. And what are they? Well, it's a pump that's surgically implanted in the chest. And the purpose of the pump is either to totally provide total cardiac output or to assist cardiac output and provide circulatory assistance. The heart is left in the chest, and the pump is attached to the heart by way of a siphon that drains blood out of the ventricle or both ventricles, and then moves the blood through the pump and then out through the outflow tract, which could be the pulmonary artery or the aorta. What kind of ventricular assist devices are there? Well, there's really three kinds. For us, the most common kind, the one we're most likely to see in the field, is left ventricular assist device. This device is used to support the pumping of the left ventricle of the heart. So blood comes into the left ventricle by way of the lungs and then is moved out of the heart by way of the ventricle through its normal contractions, but also with assistance of the pump, which helps bypass some of the flow through the ventricle and into the aorta. You may see a right ventricular assist device, and this device supports the pumping of the right ventricle. That's where there are patients who have right ventricular failure, but the left ventricle seems to be able to do its job and move blood on its own. So the ventricular assist device is implanted in the chest so that blood is taken out of the right ventricle, and then it is pushed into the pulmonary artery rather than the aorta, and blood is moved through the pulmonary artery into the lungs. On rare occasions, you may see a biventricular assist device, and this is a circumstance where there is a pump that's supporting both the right and the left ventricles of the heart and help move blood through both the right heart circulation and the left heart circulation. Again, though, the most common ventricular assist device that we're going to see in the field is the LVAD, or the left ventricular assist device. Let's talk a little bit about why are these devices implanted. Well, when these devices first came out, the original intent was to bridge these patients to the point of transplantation. So these patients had cardiac failure. The heart was not able to move enough blood on its own, and the patient was at risk for death. They put the device in, it assisted the patient, and it kept the patient going long enough until a donor heart could be found for the patient, and the patient could have a heart transplant. The second indication for implantation of a ventricular assist device, or again, in our case, LVAD, is to keep the patient alive, and the ventricular assist device in itself is the destination procedure, meaning the patient is not a candidate for a heart transplant, and the LVAD is going to be in the patient lifelong until the patient dies. We are seeing more and more of these patients who are destination patients. The device is in place to keep the patient alive as long as possible, but when the heart in the device fails, there are no other options other than replacing the device. These patients are not considered candidates for organ donation. Let's talk a little bit about the components of an LVAD. Well, there's an implanted pump. That's the internal device. It's got an intake line which pulls blood out of one of the ventricles, and it's got an outflow line that goes into the aorta. So if, again, we're talking here specifically about the LVAD, so the intake siphon or intake tube is coming from the left ventricle, and then outflow is into the proximal aorta, and the device is then implanted to help move blood through the heart. There's a device controller, which is an external device. It's the box that the patient carries, and it's responsible for controlling the pump speed, and it also provides a monitoring of the device, determine how it's functioning, and possibly set off alarms if there's a device failure. There is a power cable that runs from the controller to the pump. This is what you'll see running from the controller and through the skin of the patient into the pump, and it looks like a cable. And then there'll be a power pack, and the power pack is external. Generally, these devices come with batteries and a plug-in power converter, and generally patients have at least 2 sets of batteries and an extra controller when they're at home. So there's a lot of redundancy built into the equipment that the patient has, with the patient having extra batteries, extra power devices, and probably an extra controller as well, so that if one of these devices fails, the family member or the patient can quickly swap out. If we talk about the 2 different types of LVADs, there are really 2. One is the HeartMate 2 device, which has axial flow, meaning you basically have a blade or impeller that spins and blood moves in line with that impeller. And you have an intake tube. The blood goes into the chamber where the impeller is. It's like a propeller that's pushing the blood forward, and then it pushes it out through the tube that goes to the aorta. The second device is a centrifugal device. It basically looks like a pump. It spins, and it helps move blood in and out, but there is no propeller-like function that you might see in the HeartMate. If you look at the devices that are out there, the HeartMate is the device that's got the disc that spins, and the pump is actually implanted at the tip of the left ventricle. It sucks blood out of the ventricle, and then it runs through the tube into the aorta. Whereas the HeartMate, which is the device with the impeller or the propeller blade in it, it has a tube that runs out of the heart to the intake side of the pump, and then blood is pushed out through the pump into the tube that connects to the aorta, which then moves blood into the aorta and improves cardiac output. Some general tips regarding the LVAD. Let the patient or the care provider lead. The patient's family members or care providers are very well trained by the service or by the LVAD service. They know how to contact the LVAD nurse or nurse practitioner, and they are the local experts, or at least the expert at home when there's a problem with the device. If there is a need to transport the patient, then bring the caregiver along in case their assistance is needed, and I would make them readily available in the in the back of the truck, so that if there's a problem with the device, they can quickly provide guidance on what to do. When the patient needs transport, bring their equipment with them. Bring their travel bag with them. It has got extra controller batteries. It's got contact information for the LVAD coordinator, and it's really essential to take it with the patient. patients should be transported to their hospital record for any and all complaints, even if not related to the LVAD. I can guarantee you that ED providers do not want to have to manage an LVAD patient. I know if one walks into one of our local emergency departments, we do everything we can to transport them to their home hospital. That's because that's where the patient specialists are. If there are any device problems, they know how to handle them. Plus, these patients are at high risk for complications, which we'll discuss later. And if there are complications related to the LVAD, whether it's bleeding or a pump failure, the patient needs to be at the institution that can manage those problems. And that's their home institution. In Columbus now we have 2 hospitals that are doing LVADs. Ohio State was the original, and then Riverside Methodist Hospital. We may also see some patients in the Columbus area from the Cleveland Clinic. If you have a patient with an LVAD and an LVAD issue, I would transport them to Ohio State. Ohio State can provide care for the patient, and if necessary, make arrangements for the patient to be transferred back to the Cleveland Clinic. With these patients, when you transport, avoid kinking or twisting the drive line when strapping the patient to the gurney, and be careful if you take their clothes off or use scissors. You don't want to cut the drive line. You don't want to dislodge the equipment by accidentally pulling on any of the tubes. And then keep the batteries and the extra controller in reach and secured to the patient during transport. Keep them dry to make sure that the device doesn't fail during transport. Some other things regarding patients and assessment. Keep in mind the most common cause of acute LVAD failure is loss of power or failure of the drive line. That's why it's important to have the extra batteries, extra controller with you during transport, and have the family member who's the expert on device management with you in the cab. Patients who have an LVAD typically have either very reduced pulse or no pulse at all, so pulse rate really is not going to help you. You can't really palpate a pulse well. The best way to measure a patient's perfusion is to use a Doppler device and a manual blood pressure cuff, and you listen for the first bit of noise as you decompress the blood pressure cuff, and when you start to hear flow, that would be considered the patient's mean arterial blood pressure. And really, for LVAD patients, a mean arterial pressure of over 60 is considered normal. So a patient runs in the 60 to 90 range, they have good pump function and good cardiac output. It may be difficult to obtain O2 saturation because of the lack of pulse. It's one of those things where if you get a good O2 saturation, that's a good thing. Whereas if you can't get a oxygen saturation, it's neither good nor bad. It simply means the device can't detect O2 saturation because there's no pulse for the device to measure. The most common complications of these devices are bleeding or blood related, so bleeding either from the nose or the GI tract or into the brain. They can also have blood issues in the form of thromboemboli. They can form clots in one location that go off to another, so the patients can develop pulmonary emboli. They can have a myocardial infarction even though they've got a pump in place, or they could have a stroke. They could have right-sided heart failure, or they could have problems with pump malformation and infection. I've seen several LVAD patients who are on continuous antibiotic infusions because they've got an infected pump, and they're not really suitable for pump replacement. LVADs are preload dependent and rely on right ventricular output in order to provide adequate device filling. So anything that you have as a complication for the patient that results in inadequate blood flow to the right ventricle can result in trouble with the pump and inadequate pump and cardiac output. So if the patient is septic where they have vasodilatation of their veins, that's essentially going to decrease right ventricular filling. If the patient's dehydrated because of nausea, vomiting, or diarrhea, they're going to have inadequate right ventricular filling. If they have uncontrolled hemorrhage, whether it's from the GI tract or from the nose or from anything else, it's going to result in impaired blood return to the right ventricle. Any tachyarrhythmia, where the heart's going so fast where the right ventricle can't fill completely, that's going to result in a problem with left ventricular filling and supply to the pump. Patients who have acute right ventricular MI are going to have inadequate right ventricle output, or patients who have a pulmonary embolism, who have a big clot obstructing blood flow from the right heart to the left heart, they're going to have problems with pump failure as well. So any of these things can result in inadequate flow into the left ventricle and into the pump and result in patient decompensation. I mentioned bleeding earlier. I think we also need to mention that all of these patients are anticoagulated. So it's not just they have risk for adverse effects of having the pump, and because of the pump have increased risk of bleeding, but they also have additional potential for bleeding because of the anticoagulation that they're on. Some points made regarding the unstable patient with the left ventricular assist device present pretty much follow BLS and ACLS protocols as indicated. So if they have a need for cardiac compressions, or if they have a need for medications or defibrillation, you can do that. Again, LVADs are preload dependent and rely on right ventricular function, so be aware of those acute conditions that can impair right ventricular filling. So if you think the patient's septic, dehydrated, or has acute blood loss, give the patient fluids, because fluids will improve right ventricular filling, which will result in improved cardiac output. Also be aware of the tachyarrhythmias and potential risk for MI and for pulmonary embolism. There is an algorithm that we'll look at in a moment that they have promoted in this article regarding management of an LVAD patient who's unresponsive, and I'll talk about that in a minute. One of the key changes that I think we all have to adapt to is the recommendation for chest compressions in a patient who has decompensated and has inadequate cardiac output. And the algorithm gives us some guidance in terms of who is a candidate for this. So they do recommend now external chest compressions for patients in cardiac arrest. But again, if the patient has a total artificial heart, which is basically a mechanical pump in the chest, compressions aren't going to do anything. If the patient has a need to be defibrillated or be cardioverted, you can do that. Just don't place the defibrillator pads directly over the implanted device. So you may need to make some adjustments in pad placement. A couple key points to be made regarding patient assessment. A patient who's awake, alert, and has normal mentation should be considered to have adequate perfusion regardless of what you're able to get as vital signs. So if you're really not able to get a good mean arterial pulse, but the patient is awake and alert and is talking and thinking clearly, then they're getting adequate cardiac output. If you're able to obtain a mean arterial pressure by using a Doppler device, a mean arterial pressure of greater than 50 millimeters of mercury is considered a good finding. If you're in a situation where you had to intubate the patient, you can measure end-tidal CO2. If the end-tidal CO2 is over 20, that's considered a good indicator of adequate perfusion and adequate cardiac output as well. Now, the article makes a point that supraglottic devices like iGel or King device are not appropriate for measuring CO2. I think this is contrary to what we've been told elsewhere. But I think from the perspective of the patient who is in cardiac arrest or who's unstable and has a LVAD in place, I guess we can't rely on end-tidal CO2 unless they're intubated. Here's the algorithm I talked about. I think it's kind of a good way of looking at patients, and I think it tells us how to assess the patient. So, the bottom line is we start with ventilations and assess perfusion. If the patient has normal skin color and temperature, and normal capillary refill, and their mentation is normal, then we should consider the device to be functioning adequately. And to have patient to have adequate perfusion. If we think the patient is perfused adequately, we can assess and treat for any non-LVAD problems that could result in altered level of consciousness, such as hypoxia, blood sugar overdose, or stroke. Again, these patients are all anticoagulated, so they are at high risk for intracranial hemorrhage. Always think about a head bleed in these patients who have altered LOC. If the patient has inadequate perfusion based on skin color and capillary refill, look at the LVAD and see if it's working properly. If you don't know how to assess it, then ask the care provider to assess it. But are there any alarms going off? Listen to the chest and see if you can hear the LVAD operating, because if you listen to the chest on these patients, you'll hear a loud mechanical hum as the device moves blood through the heart. If the LVAD is functioning, if it's not functioning, then attempt to restart the LVAD, check the drive lines, check the power source, see if the batteries need to be changed, and do you need to replace the system controller. Patients do have contact information for their LVAD coordinator. You can contact the coordinator if family member is not available, but again, see if the family member is available to assist with the troubleshooting process. If the LVAD restarts, then fine, just follow your EMS protocol and get the patient to the hospital. Let's assume the LVAD is restarted and the patient still doesn't improve. Well, then you can start cardiac compressions. That's the green box at the middle of the page, kind of toward the bottom. And to just do compressions as necessary to get the patient stabilized and transported to the hospital. They do recommend manual compressions. I would not use a mechanical device, and I haven't really found good definition of whether or not to use the device in these patients now, but I would stay away from mechanical compression device if they have an LVAD, even if they're in arrest. If you assess the patient and the LVAD seems to be working and they're still not perfusing well, then they make the recommendation of looking at the mean arterial pressure, and their break-even point is better than 50, and checking the end-tidal CO2 if the patient is intubated. So if the mean arterial pressure is over 50, that would be considered a sign of adequate pump function and adequate perfusion, and you do not perform CPR on the patient, and you look for other causes that may require treatment. If the patient has an endotracheal tube in place and their end-tidal CO2 is over 20, that's another indicator that the patient has adequate perfusion and CPR is not indicated. However, if you evaluate the patient and their mean arterial pressure is less than 50, you should start CPR. If you get able to get an endotracheal tube in and their ETCO2 is less than 20, then you should continue CPR even if the patient's intubated and their mean arterial pressure seems to go up. So I think this is much better guidance than we've had in the past. We have to change our habit of not doing CPR in patients in cardiac arrest who have LVADs. We've confirmed that Ohio State in particular, and we're still working on Riverside, but we've learned that Ohio State wants us to do CPR in their patients now. And I think this flow chart is a good way to look at our patients and assess them. So that's all I have regarding LVADs. I appreciate your time. If you have any questions regarding this topic, please send them to me or post them via Workplace. That way I can respond to you, and everybody else in the audience can also hear the follow-up.